Yang malam Windows tuh.
Kan ya, tadi dong green.
Apa cerita di penjual
Ada di smoothie sebenarnya cuma aja.
tapi aku dua kedatangan tanpa ya kalian
Oh, nga itu ya.
kan aku video katnya
Oh, stop. Nama kamu kan akan ganti sih. Mau out boy. Usai.
Okay, thank you. Yes. Actually, technical issue था. Sorry. We are late, but. No, no, actually, no, some this technical issue. Good afternoon, everyone. Really sorry for the technical issue, and those participants who are not able to join, we have shared a live YouTube streaming link in the chat box, and I will be also sharing in the WhatsApp group as well. So I request those participants who are not able to join here, please share the link among your friends so that at least they can join in the live YouTube streaming. And from there also we have shared the this thing attendance sheet also. Whoever are joining from there also, we will take it as a present. So I'm really sorry for the technical glitches that had happened just now. And good afternoon, everyone. I think once ma'am, you are able to hear us. Once ma'am, are you there? Can you check the type the Dr. Mansa? Give me this both. Give me that and that keyboard also. You told me only library. That's why I went. Once ma'am, you are there?
Jankalia, she's there.
Hello, Dr. Mansa ma'am. You are able to hear us? Hello, Dr. Mansa ma'am. She's not Mansa.
नानू का मैम वंसल नहीं है, ये कोई और है। तो
Really sorry. Let's wait for this in few more minutes. And those people who are coming from the Nigrims itself, can you please come to the library and you can join on site as well? We are keeping your attendance. So I request all the Nigrim staff, those who are joining from your ward and from OPD and all, you can come here and you can attend and you can logged out from this Zoom so that at least other people will be able to join. We are waiting our presenters to be joined, then we will start. I'm really sorry for the inconvenience. And again, I'll request Nigrim staff, those who are joining from the hospital, please log out from this link and then you can join from here on site. Thank you. Tiji, can you please share the pretest in the chat box? So by the time those who have already joined, they will at least do the pretest.
Yes, yes.
And please, those who are not able to join, please share this YouTube link and tell them to join from YouTube live streaming. Okay. Ma'am, you are there? Dr. Vansa ma'am, now you are here? Hello, Vansa ma'am. Can you hear us? Hello? Vansa ma'am, you can unmute yourself. Ma'am, you are co-host. I think you can do that one. Okay. Not able to start also. Ma'am, your name is written as a Vansala Sulai Unil, ma'am. You have, yes, ma'am, we have make you co-host also. You're not able. Oh, okay. Many participants are doing a pretest, ma'am, so I think she's not able to.
Ma'am, Vansal ma'am, can you unmute yourself, please?
Hello, Vansa ma'am, you are able to hear us? I think Jyotiji, Vansa ma'am is saying she is not able to unmute and switch on her video as well.
So we cannot do from here, but she has to unmute at
Yeah,
least.
she need to unmute herself.
Abhi, right now?
No, she's already co-host, but she is saying she's not able to unmute.
We cannot do.
Can you unmute her? This is Dr. Vansala, co-host. Can you please unmute her from your side?
No, I'm saying ask to unmute.
Ask to?
Yeah, yeah, I can.
हाँ अब मैंने परमिशन तो दिया है। हाँ आगे
Hello, Vansa ma'am. I'm really sorry.
मैम किसी और डिवाइस में अगर आना चाहे तो आ जाइए अगर वो डिवाइस ओपन है वंश मैम अगर आप किसी और डिवाइस पास में है तो इसी डिवाइस में भी आ जाइए हो सकता है आपकी डिवाइस में कोई प्रॉब्लम हो तो आप अनम्यूट नहीं कर पा रहे हैं
Hello, ma'am. Can you try once again just to unmute your mic? Hello.
Mute all. You cannot do mute all.
I have this thing. I have given the chances for the participant also to unmute. This one I have allowed.
But you from here, if you do, can then what happened?
No, it's not happening. See.
No, only mute all, and then after that you can again unmute all. Why you are not allowing?
No, it's already allowed participant to unmute.
Yeah. Now mute all.
I'm trying.
Like,
Hello.
चालू करता है, तू लिंक पे भेजूंगा मैं मुझे। Yang dan company video lah. Tidak soalnya lah. Mudah yang bibir ya soalnya.
Hello. Good afternoon, everyone. I think we will start with our second presentations.
no, you already done with introduction.
Nanuka, I'm able to log in now. So I
Okay.
think we can start. Yeah. Nanuka, are you able to hear me?
Yes, ma'am. I can hear you, ma'am.
Yeah.
Yes,
So now I'm
I-
able to log in. Yeah.
Okay, thank you so much, ma'am. So, good afternoon, everyone. Really, really sorry for the technical glitches that had happened just now. So, good afternoon, everyone, and Happy New Year. So, without, I think, much delay, without much delay, I will just start. We will just start our today's sessions. So, today we are having three presentations, and we wanted to do the discussions after each sessions. Okay, and for that I request all the participants to actively participate in the sessions. You can write down your queries in the chat box, as well as you can write down in YouTube also, so that from there also we will read your questions and we will try to clarify your queries. So, starting with our first sessions, I would like to introduce our first speaker, Dr. Vansala ma'am. Ma'am is working as an assistant professor here in Department of Obs and Gynae in IGRIMS in Ceylon. Ma'am has done a MBBS from the Pondicherry and Masters from Rohtak in the year 2012, and senior residency was doing in 2016 in New Delhi, and done fellowship in the same year. So I think I'm not going to read all details, but ma'am's area of interest is infertility, emergency obstetric, and minimal invasive surgery. So thank you, ma'am, to being with us, and I just wanted to hand over the platform for you. Over to you, ma'am.
Okay. Thank you so much. Am I audible?
Yes, ma'am, you are audible.
Okay,
Ma'am, you want
perfect.
me to share the screen, or you will share from your side?
I will do it from my side. I
Okay.
think, just hold on. Yeah, is it visible, and am I audible?
Yes, ma'am. Yes, ma'am.
Yeah,
It's
okay. So, a very good afternoon to everyone, and I would like to thank Japaigo for giving me this opportunity. So, I think we're a bit behind schedule by almost 50 minutes. I think everyone has been launched in and launched out. So, when Nanuka had first approached me to conduct this webinar, it was sometime in the month of October, and things just got postponed again and again. But in a way, Nanuka, I'm glad that we finally are able to do it in the month of January. Why? Because January is actually celebrated as the Cervical Cancer Awareness Month. So I think it's very apt that we are finally able to do this talk in this particular month. So I've been given the topic of screening of cervical cancer. And in today's talk, I'm going to talk a little bit about the burden of the disease in India. We are going to look at what is cervical cancer screening, the rationale behind it, and a little bit about cervical histology, but I promise I'll not bore you too much with that. We are also going to look at the types of cervical cancer screening modalities available in our country, the techniques, and of course, the screening schedule, meaning when do we start, how often do we have to screen, and when do we stop cervical cancer screening. So coming to the disease burden in India, where do we stand as a country? So cervical cancer is the second most common malignancy amongst Indian women, only second to breast cancer. And what is the incidence? As per the Indian Council of Medical Research 2018, the incidence is at about 122,844. And according to the Global Cancer Statistics of 2020, the incidence is 123,907. So we're talking about new cases. And what is mortality per year? Again, ICMR and the global statistics, they keep it at 67,477. And according to the 2020 statistics, that stands at 77,348 mortalities per year. So this is a very, very significant number. And if you look at the 5-year prevalence, it is at 283,000 odd number of cases. And what we should also remember is that rural women are at a higher risk of developing cervical cancer as compared to their urban counterparts. This is of significance. We'll talk about it a little bit later, why this is so important. So therefore, when we look at our country, when it comes to the incidence or whether the mortality, we account for almost 1/4 of the total world's mortality and incidence. So that is a very, very significant number, which is why today's topic is so important, right? So cervical cancer screening is especially even more important in our Indian setup because we have one of the highest incidence, and we also contribute to 1/4 of the mortality related to cervical cancer worldwide. So now what are the goals? Now the World Health Organization has come up with this global strategy to accelerate the elimination of cervical cancer by 2030. So there are 3 pillars according to the WHO. Number 1 is 90% of girls to be fully vaccinated against HPV by the age of 15. The second pillar is 70% of women are to be screened with a high performance test by 35 and 45 years of age. So this is the minimum that the WHO wants, and 90% of women identified with cervical cancer will receive treatment either for precancerous lesions or invasive cancer. So what we are going to stress on today is on the pillar of screening. And what about the UN? What about the Sustainable Development Goals? According to these goals, there's a need to reduce mortality due to cervical cancer by 30% by the year 2030. So whether it's the UN or the WHO, both of these aim to achieve these goals by the year 2030, which is not too far away. So therefore, coming to cervical cancer screening, what is it? So cervical cancer screening is used to find changes in the cells of the cervix that could lead to cancer. So please remember that this is a screening modality. Right? So why is there rationale of screening? Now, the thing with cervical cancer is that it has a very long pre-invasive state, and therefore it is considered to be preventable. So if we screen a woman for cervical cancer and we actually detect these pre-invasive lesions, by having treatment and proper management on time, we can actually prevent the disease progression. So this is the beauty of cervical cancer. If we can catch it or we can screen for it earlier on, and thereby we are going to identify these precancerous lesions earlier and therefore manage them earlier, this can help prevention of the disease from a pre-invasive to a cancerous state. So if you look at cervical cancer screening, it is a form of secondary prevention. Right? So prime prevention is HPV vaccination, which I think the next speaker will be talking about. But in my talk, I'll be mainly concentrating on screening of cervical cancer, which is a form of secondary prevention. So if we look here, if we have a person who's uninfected and the person actually gets vaccinated, and suppose there is some form of HPV infection, what we should understand is that whenever someone is infected with HPV, it can regress in most women, but in some of them, it can persist and progress. And if we are able to detect these changes that are brought about by HPV, or if we can detect HPV infection, we can actually halt disease progression by timely management. Right, so I'm going to bore you a little bit with the histology. This is important for us to understand in order to further understand how screening of cervical cancer works. So you can see the schematic representation here. We have the cervix and the vagina. So the cervix is further divided into the endocervix, okay, which is the upper and middle third of the cervix, and we have the ectocervix. So now this endocervix is lined by something known as the columnar epithelium, which is a single layer of well-lined cells. Are you able to see my cursor on the screen, Anuka?
Ma'am.
Yeah, okay. So we have the endocervix, which is a single layer of columnar epithelium. And then you have something known as the squamous epithelium, which lines the ectocervix, meaning the outer part. So this squamous epithelium, as you can see here, they are multiple layers, right? So this is your squamous epithelium and this is your endocervix, which is lined by the columnar epithelium. And therefore, the junction between the columnar and the squamous epithelium is known as the squamo-columnar junction. But it is not that simple. There's something known as squamous metaplasia. Now, what is the squamous metaplasia? The central ectocervix and proximal endocervical canal, there can be replacement of the columnar epithelium of the endocervix by the squamous epithelium of the ectocervix. So this is metaplasia, which is absolutely physiological. Now, what happens because of this metaplasia, squamous metaplasia, we have something known as the original squamo-columnar junction, right? And because of the metaplasia that happens, we are going to have a new squamous-columnar junction, because some of these columnar cells are going to be, by the process of metaplasia, they're going to be squamous. So we are going to have something known as an original squamous-columnar junction, right? And then we are going to have something known as a new squamous-columnar junction, or the functional squamous-columnar junction, right? So then this is very important for us to understand. Why? Because the transformation zone, right? So when we are going to take a cytology specimen, when we are going to take a pap smear, this is where we're going to take the pap smear from. It is known as a transformation zone. And what is the zone? The zone lies between the original squamous-columnar junction, and because of the metaplasia, we're going to have something known as the new squamous-columnar junction, and the area between these two is known as the transformation zone, right? So you have a schematic representation here, right? So for understanding the area between the original and the active squamous-columnar junction is known as your transformation zone. This is very important for us to understand, because this is a site where, if at all any pre-malignancy or malignancy develop, this is the most likely site where it will start on the cervix. And therefore, whenever we are doing screening for cervical cancer, if we are going to do cytological screening, we have to take cells from this area. Right. So a little bit, so we've spoken about the cytological aspect of it. Now we've understood that if you're going to take cytological specimen, we can't just take it from anywhere. We have to take it from the squamous, from the transformation zone. Now, if you look at the HPV infection, now most of our squamous epithelial lesion, or CIN as we call them, are caused by HPV infection. Now, I've used the word mostly. I'm not saying all are caused. Now, when we look at your HPV, right, the human papilloma virus, there are more than 100 types of human papilloma virus, and they cause a wide range of diseases. Now, out of these 100 types, 15 are linked with cervical malignancy. And out of these 15, the most common, which is implicated in more than half of all cervical cancer, is HPV strain number 16, which is why, again, when we have our speaker talk about HPV vaccination, they're going to talk about the various types of vaccines available, right? So as you can see, this is important to understand, because there are about 15 strains implicated, out of which HPV 16 is implicated in more than half of all cervical cancer cases, right? So this is very important to understand. So therefore, what does screening do? Now, if there's screening, routine screening of women, and again with vaccination, this can drastically decrease cervical cancer rates. So coming to the screening modalities, there are mainly 3 screening modalities. Number 1 is molecular, where we look for the presence of your human papilloma virus. So we've spoken about why HPV is important. It's implicated. Not all, but most of these cervical cancer lesions are because of HPV infection. Now, the second is the cytological, which is the Papa-Nicolau smear, or in short, we call it the pap smear. Now, when we do a pap smear, it can be conventional, wherein we use the eye spatula, or it can be liquid-based, where we use a cyto brush. And of course, thirdly, visual inspection by acetic acid. So why is it important for us to have 3 types of screening modalities? Why not just stick with one? This is because there are certain places where HPV testing is not done, right? And where PAP is easily available. Or for example, in rural setting where we cannot expect a pathologist to be there, or we cannot expect a lab to be set up there, VIA will be the most apt form of screening. So this is the reason why we have 3 main types of screening, because the government is pushing us towards screening more and more women. And if you remember from my earlier slide, I mentioned that rural women are more prone to getting cervical cancer as compared to their urban counterparts. So coming to the pap smear, what it does is that it looks for pre-cancer cell changes on the cervix that might become cervical cancer if they're not treated appropriately. So basically, it's a cytological test. Why? Because we're looking for the cell changes, the precancerous cell changes. Now, what the HB test does is that it's a molecular test. Why? Because we are trying to detect the virus, which is the human papilloma virus. Right? So a little bit about the pap smear. Pap smear is a routine, it can be done as a routine OPD procedure when the patient lies in lithotomy position. We are going to insert a speculum, preferably a Cusco speculum. Now, it's very important to remember that we do not use any lubricant, right? So these are the technical aspect of it. And then what we do is that after using a Cusco speculum, the beauty of this is that you do not need an assistant. You can do it on your own. And then what you do is that we are going to identify the squamous-columnar junction or the transformation zone. And we can either use an IS spatula or a cyto brush to sample the cervix. So this is how it would look like. Now, in this picture, the IS spatula is being used. So this would be a conventional PAP. So after sampling the cervix, if it is with IS spatula, we have to make a smear on a slide given. So this is conventional PAP. Right? So how do we identify the squamous-columnar junction? It'll be this area, the junction of the pink and red endocervical canal. So this is your transformation zone, right? And like I mentioned earlier, this is the site which is most likely for this place here to happen or to begin in, right? So which is why we are going to sample this area. So this is an IS spatula. It has a concave end and a convex end. So this is the concave end that we're going to insert a little bit into the cervical canal, and we're going to rotate the IS spatula, and then we're going to get cells which we are going to prepare on a slide, right? So we're going to rotate it 360 degrees. Make sure that when we are going to do the sampling method, we are not going to use too much force, otherwise there'll be bleeding. And at the same time, we should not be way too gentle that we don't even get adequate sample. So this is how it looks like. This is the squamous-columnar junction. Right. Now, cyto brush on the other hand, what we're going to do is that we need not rotate it a full 360 degrees. We can only rotate it a 180 degree. So this is for your better understanding. We have an IS spatula here. Okay, we're going to insert it there, rotate it 360 degrees, while as with a cyto brush, even 90 degrees is enough, but more often than not, we rotate it for 180 degrees. So this is how we sample. Now, like I said, if we're going to use the IS spatula, it's called conventional, and we're going to make a slide. Now, in case of the cyto brush, right, we need not do that. Now, when we are going to make a slide with the IS spatula, after we take the sample, we need it to be fixed on the slide, right? So it depends. Now, there are routinely what we do is that we have 90% alcohol, which is used as a fixative. So it comes in a container. We're going to keep the slide there. Now, for liquid-based cytology, what happens is that the end of the brush, we can just break it. There's already a marking. We just have to break it and put it in the transport medium. Right? So this is how it looks like. Okay, in case if you're going to use a cyto brush, there's a marking somewhere around here. After taking the sample, we can just break the end and send the brush in situ inside the container to the lab. So I'll just skip this fixation. Right now, we don't use in NICRMs, we have started using liquid-based cytology. We no longer do conventional cytology. So there is an advantage. There is a reason why we do prefer liquid-based cytology to your conventional pap smear. There are many advantages, right? So the number one, we do not have to prepare evenly spread smites. This can take a little bit of time, especially in a very high output, high volume center. It can be a problem. If you're going to take 40-50 pap smears, it's going to take a lot of your time. And we have to do it immediately before the cells become air dried. Again, that can even alter the final findings. Again, LBC preparations are uniformly well fixed because you're going to keep the entire cyto brush inside the liquid container. And after that, cells are also not obscured by exudate or blood. right? So all these are the advantages, but the greatest advantage of liquid-based cytology is that it allows us to do ancillary tests such as HPV testing, right? So the same sample can be used both for cytology and we can even do HPV testing. Right. So now coming to, so we are done with cytology and HPV testing. We're going to take the same sample with our cytobrush and then send it for HPV testing. And what's going to happen is that they're going to detect if there's any HPV infection or not. Now coming to the third modality of cervical cancer screening, it is known as visual inspection with acetic acid. So for visual inspection of acetic acid, all we need is a speculum. We may need some gauze piece to clean the cervix and 5% acetic acid. That's it, visual. We do not need any microscope for it. So thereby we do not need a pathologist or we do not need a well set up lab for this. So all we need is to just apply this 5% acetic acid on the cervix, leave it for a minute, and then we are going to look at the changes. So in a resource-poor country like ours, VIA has a lot of importance, right? And it's also shown to be equally sensitive as cytological screening methods. So like I said, in a rural setup, you know, in a place where they do not have very fancy machines or they do not have a lab, we can do VIA. So what is this visual inspection with acetic acid? It's very important for us to understand what exactly happens. Now, when we apply acetic acid, 5% acetic acid to normal squamous epithelium, little coagulation occurs in the superficial cell layer as this is very sparsely nucleated. So the normal squamous epithelium appears pink, if you remember all the pictures I'd shown earlier, and the columnar epithelium appears red. So we've seen the earlier pictures how a normal cervix looks like. Now, suppose we have a patient who has areas of CIN, cervical intraepithelial neoplasia, or any pre-invasive or invasive cancer. What will happen is that once we apply this acetic acid, there's going to be coagulation. Now, what causes this coagulation? This is because of the higher content of nuclear protein. So it is this protein that is going to coagulate. I think we all know by now from our chemistry classes that if a protein can coagulate, so higher protein, higher coagulation. So in a normal cervix, because the cells are sparsely nucleated and therefore the protein content is lesser, there'll be no coagulation. But if there's any abnormality, so if any abnormality happens, what will happen is that there'll be higher content of nuclear protein, and it is this protein which is going to coagulate. Now, when something coagulates, right, it will prevent light from passing through the epithelium. So it will be, and as a result, the subepithelial vessel patterns obliterated and the epithelium will appear densely white. So it will become opaque and therefore do not allow the light to pass by, and therefore the subepithelial vessels will not be seen. So what picture do we get? We get white. So anything that is abnormal will appear white. Anything that is normal will appear reddish pink. So thus, the effect of acetic acid depends upon the amount of cellular proteins present in the epithelium. Areas of increased nuclear activity because of their higher protein content, okay, they will exhibit the most dramatic white color change. So we just have to understand this to do a visual inspection with acetic acid. Just one slide. For those of us who are there in the periphery, you'll understand that all you need is 5% acetic acid. You need just a speculum, and of course, you need some gauze swab to just apply the acetic acid. That's it. Okay. So this is how it looks like. So when we are going to apply visual acetic acid, we're going to keep the gauze piece in situ for 1 minute. That's very important. And the correct percentage is also very important. The percentage that we use is 5% of acetic acid. So, okay, so you tell me now, is this normal or abnormal? If anyone can answer the first picture here. Anyone? So when you're going to apply acetic acid, if it looks reddish pink like this, Does it indicate abnormal finding or normal finding? No? Okay. So reddish pink meaning it is normal, right? But if it becomes white like this, right? Or say like this, or this picture here, right? It means that all these areas are abnormal. So for example, even in our clinical setup, when you're in tertiary care center and sometimes you do a pap smear, it becomes abnormal. Sometimes I may have to rely on acetic acid. And suppose, for example, if you look at the second picture here, now if I were to take, say, a biopsy for confirmation, and I take a biopsy, say, from 11 o'clock or 1 o'clock position, I may actually miss the lesion, which is here between 4 and 7 o'clock. So this also will aid me. So when I put the acetic acid and I see a lesion here, I can actually take a biopsy from there for definitive diagnosis. So this is the other use of acetic acid, right? So the first picture here shows the normal squamous-columnar junction, which is supposed to be pink and plum, right? But once there's abnormality, you can see the increased intensity of abnormality, it'll become more white. And in this, you can clearly see that this is absolutely an abnormal finding. Right. So like I said, these are the, when you do visual inspection with acetic acid, if it's VIA positive, so what will the report be? It'll either be VIA positive or VIA negative, right? So in positive, what will happen is that the appearance of these white lesions are very rapid and they may last for a long time, unlike in your VIA negative, right? The color intensity is shiny and cloudy white. It is more dense, thick, and opaque, just like what is seen in this picture here. And the borders are well demarcated, regular rays from surrounding epithelium, right? And usually restricted to transformation zone. And of course, the color uniformity is uniformly white. So when we have all these findings, we can write VIA positive. So your screening becomes a positive test, right? So again here, just to show you, after application of 5% acetic acid for 1 minute using a swab, cotton swab, we are going to wait for it, okay? VIA positive, you can see all these white areas here, right? Very irregular. And in case of VIA negative, it remains pinkish red. So now we've spoken about the 3 screening modalities. We've spoken about cytology, that is your pap smear. We've spoken about HPV testing, and we've spoken about VIA. So which of these is the best? Now, our guidelines say co-testing. Now, some of them are saying co-testing with HPV and cytology is superior, but the consensus is as long as we do any form of screening, it is better than not doing a screening at all. So if you're in a periphery center, in the rural setup, doing a VIA is good enough, because we cannot. Now, what we should understand about screening is most of these are healthy women. They do not have any problem. Why should they come to a health care facility? Why should they come? For example, today I had to drive down from Cherrapunji to come and give this talk, and it took me 2.5 hours with traffic. So I specifically came, I had to cut down. I was staying with a friend, I had to cut down just to come and give this talk to ensure that I have my internet connectivity. Now, if I do not have, why should I drive down 2.5 hours? Right? So now imagine for a woman who's absolutely normal, and you want to do a screening for cervical cancer. Why should she come all the way to the city through 2.5 hours of traffic, 3-4 hours of traffic? So which is why the consensus is that you can do it in a PHC and a CHC, where all you need is acetic acid, and you just understand the theory behind what exactly happens in VIA. That is enough. So the doctor or the healthcare worker who's manning that center there can do a VIA for these patients. So in rural setup, or we call them limited resource setup, VIA is considered to be as accurate as your cytology, right? So if you look at the sensitivity here, it's comparable, right? Cytology is 62 to about 72, and even your VIA is about 74 or so. So if you look at the sensitivity, it is comparable. Specificity slightly lower than the cytology. Of course, they say HPV co-testing is the preferred model, but like in limited resource setting, VIA is good enough. So then, like I said, what tests do we do in what setting? So in case of a good resource setting, HPV, either co-testing or as a primary test, or cytology, meaning your pap smear, and in limited resource setting, VIA, right? Now, what is the target age group? In a good resource setting, we are going to start at about 25. I'm talking about married women here. And in case of limited resource setting, we can start at 5 years later at 30 years of age, right? So then here, if we are going to do primary HPV testing at 25, co-testing at 30, and in case of limited resource test setting, 30 years is a good enough age to start. Now, this is very important to understand. If we are screening with pap smear, the frequency has to be every 3 years. Okay, even if the patient is asymptomatic, we must advise her that, look, your pap smear is negative, but please come again, in 3 years' time for us to do a repeat screening test. Now, if it is an HPV test or a co-testing, meaning HPV plus cytology, we can wait for up to every 5 years. So the frequency will depend on the type of screening modality that we have used. And again, in a limited resource setting, they say once every 5 years is good enough, but in a lifetime, it has to be at least 1 to 3 times. And if you look at the WHO, they're stressing 35 and 45, at least twice in a woman's lifetime, she must be screened for cervical cancer. Right? So again, when do we stop? We've understood when do we start? How frequent we do it depends on what type of screening modality. When do we stop? Now, the consensus is that 65 with consistent negative results in the last 15 years, right? And women with no prior screening should undergo tests once at 65. And if negative, they can exit screening. So what is understood is that 65 years is a good age to stop if the previous tests in the last 15 years were all negative. Okay, so this is very important to understand. So to conclude, cervical cancer screening is so important. It's something that can be easily done whether in a tertiary care center or in a primary care center. And cervical cancer screening aims to evaluate asymptomatic patients. How does it evaluate this? By looking for dysplasia, which is an abnormal finding, or finding invasive cervical cancer. And what cervical cancer screening does is that it decreases cervical cancer rates and decreases mortality rates. And what it actually increases is cure rates for invasive cancer. So I believe, if those of us, I can see 99 plus 500 participants in today's webinar, we can create a ripple effect. Now I can ask the married ladies out there, how many of you have done a pap smear? If no, please go and get it done. And if you can motivate a friend, your sister, your mother to do a cervical cancer screening, I feel my job today is done. Just giving this talk for me, it took me barely half an hour, right, to give this talk. But then if you can create that ripple effect, it's something so convenient, it is not painful, and it is in most of the setup, you barely pay anything. I think it's 100 rupees if at all, but most VIA, you will not be charged. Even if you come to Nigram's, nothing will be charged. So if you can motivate any married women that it can be your friend, your neighbor, your sister, yourself. Okay, so I feel my job today is done. Okay, thank you so much.
Thank you so much, ma'am. Thank you so much. So I request all the participants to write down your queries in the chat box. Ma'am, you can do the stop. Okay.
Yeah.
Yes. So I request all the participants to write down your queries in the chat box. First, we will do the discussions for this topic, and then we will start our second session. So till now, I have not received any queries, even in YouTube also, I'm not able to see. Anyone wants to share your experience, anything, even if you want to share, you can please raise your hand so that we will give a chance to talk. Yes, ma'am, thank you so much. Even though there is lots of technical glitches, but the presentation that happened so smoothly. So thank you so much.
Thank you, Nanuka.
Yes, ma'am. Ma'am, one question has asked by Ribahun, like, what are the age to start the screening for cervical cancer?
Yeah, so I've mentioned it there. In a married woman, of course, we're going to start it at 25 to 30 years, depending on what is the setup. In rural setup, they say we can wait up to 30 years. It's okay. But ideally, 25 years onwards. This is for our Indian population, right? So whatever guidelines I've shared today are all catered to our Indian population, right? The West have separate guidelines, but I've only taken what our ministry and what our government is advocating, right? For better understanding, I don't want to create too much of confusion, but 25 to 30 is an ideal age to start cervical cancer screening.
Okay, thank you. I think Ribasun, you have got the answers. Ma'am, another questions. We will take one more question, then we will jump to the next
Yes,
session.
yes.
So one question has asked, like, when should a woman screen again if the test was once came positive, ma'am?
No, so that's what, if the test is positive, we will not stop there. So what this is just a screening, it's not a diagnostic test, remember? So if the test is positive at any point, we have to follow it up with a biopsy in the same setting. Like suppose I'm doing a pap smear for a patient, the report comes after 10 days and the report is not really good, right? So what we are going to do is that we are going to do a biopsy. Right. Now, suppose the biopsy is negative, then obviously the frequency of screening will also increase, but we will not just leave it. Please remember, these tests are just screening, they're not diagnostic. So if there's anything abnormal on any of the screening tests, we have to go for diagnostic, which is usually a biopsy.
And then I think for normally for all the women, once they started,
Yeah, so what I said, the
every
frequency is,
three.
it depends on what type, what modality of screening you're using. If it's a pap smear, which is a cytological test once in 3 years, but if you're going to do HPV testing, we can wait up to 5 years. So again, the age of screening, the frequency of screening will depend on the modality, which of the 3 screening tests that I spoke about, which one have you used, okay? So if it's pap smear, once in 3 years, if it is HV, once in 5 years. But again, like I said, WHO said if that is not feasible, at least twice in a lifetime, a woman should be screened for cervical cancer at least twice in a lifetime.
I think, thank you so much. I hope you got your answer, ma'am. I think now it's limitations of the
Okay.
time. So I think we will
Yes.
jump to our next session. So
Yeah.
ma'am,
Okay.
once again, thank you so much for
Yeah.
the
Thank
wonderful
you. Thank you
session.
for having me. Bye-bye. Yeah.
Thank you, ma'am. Thank you. Okay, so now I would like to request our next presenter, Dr. Nalin ma'am. So ma'am is working as an additional.
You can
Ed-
share that.
Yes, ma'am. I'm just trying to. So now I wanted to request our next presenter, Dr. Nalini Sarma. Ma'am is working as additional professor in Department of Obs and Gynae here in Nigrims. So ma'am has done laparoscopic surgeons and a member of many societies and has done more publications more than 85 and has a multiple extramural project with ICMR. So ma'am, thank you so much for being with us. Okay, I think. Okay. Let me is your position. Give me a 1 second. So I hope my screen is visible. Jyotiji, my screen is visible. You can write.
Yes, yes,
Yes,
yes, it is visible.
okay.
Yes.
Okay. So over to you, ma'am.
Hello, good afternoon, everybody. Actually, this topic supposed to be taken by Dr. Santa Singh, our HOD, but he is quite busy. So one day before yesterday, I came to know that I have to take this topic. Apart from that, second thing, when we see what are the schedule, like first topic was screening of cancer cervix, second was prevention strategies, and third was HPV vaccination. So it seems to me like it may be administrative things I have to share. Because the third topic is HPV vaccination. So there will be repetition of some slides because I will cover little bit, because prevention strategies cover both the things, vaccination as well as this screening, what that Dr. Vansa covered. And third thing, little bit I will cover the administrative part. So I will start with my presentation. My slide, I cannot. You remove that part, otherwise I cannot see whole this topic. You have to remove this one. Yeah. So already regarding this statistics, Dr. Vansa very well covered cervical cancer, the fourth most common form of cancer among women worldwide. What are those three cancer? Breast, lung, and colon cancer. And cervical cancer is the fourth most common. And it is the second most frequent cancer among women in India after the breast cancer. And it is the second most frequent cancer among women between 15 to 45 years age. And when we see the statistics in India, already previous speaker covered that new cases are 1,23,000, and out of that mortality is 77,000 annually with cancer cervix. Next. And when we see, so cervical cancer is one of the most preventable because we are having vaccine, and not only preventable, it is treatable if we diagnose in an early stage. And screening and vaccination are key to prevent the disease. In spite of that, yet in 2020, more than 6 lakhs women were diagnosed with cervical cancer worldwide, and almost 3,55,000 died from the disease. And when we see incidence, so like 75% of the cases occur in the developing country or low resources, poor resources country. So when we see incidence, so incidence of cancer in 75 per 1 lakh in developing country and 10 per 1 lakh in developed country. So it is a public health problem. So WHO called that, yes, it is a public health problem, and we have to take some action so we can decrease incidence 4 per 1 lakh. And that's why WHO gives some guidelines. So we discuss those guidelines. Now can I use cursor? Yeah. So can you see this chart? So here in the x-axis, there are age of the patient. So when we see, after adolescent, when sexual activity begins, then there is an increase in incidence of the HPV infection. Okay. So from normal, patient gets infection. What is with this HPV infection? It will be cleared, or when this HPV infection persists, there will be development of the pre-cancer, that is known as pre-invasive state. Again, this pre-cancer, again, it will be regress and it will be normal, but in next 10 to 15 years, this pre-cancer convert to cancer. So we can see age-wise. So before 25 age, HPV infection rate is quite high. If this HPV infection persists, that is most important thing. Then it will lead to, so the age of the pre-cancer is 30 to 50. That's why we are having different modality of screen, in which age what we should screen. And then after 50 age of after 40, the incidence of the cancer is increasing. But between 30 to 50 years, there is a pre-invasive state. That's why in screening, about previous speaker told when we should start screening. So it's 30 years. Again, I will come to this graph. So you can understand the timeline and natural history of the cervical pre-cancer and cancer. Now, because it's a public health problem, that's why WHO called to all the countries that we should take some action so we can decrease global strategy to accelerate the elimination of the cervical cancer as a public health problem. And what is our target? From 75 in developing country, we have to go to 4 per 1 lakh. So we are having 3 strategies. Now, what is these 3 strategies depends on the which concept. So to control any disease, you might study like it's a primary prevention, it's a secondary prevention, it's a tertiary prevention. What will happen in primary prevention? In primary prevention, the person is healthy and we are vaccinate that person against that disease. So we do some intervention. We do some intervention before the disease develop. That is primary prevention, and primary prevention we give HPV vaccination. Here WHO give target that 90% adolescent girl less than 15 years of age, they should be vaccinated by 2 doses of vaccine. And now what is the second target? Second target is the screening that the previous speaker very well covered. So in 70% screen, like a woman 35 at the age of 35, almost 70% of the women should be screened. And again, second time at the age of 45, again, these 70% women should be screened. So this comes in the secondary prevention. So what is secondary prevention? We should diagnose the disease in early stage. So we are trying to diagnose the disease here in the pre-invasive state. And in pre-invasive state, we are having treatment. Okay, it's not like we diagnose the things and we leave the patient. We have to do something. We are having treatment. If we treat these women pre-invasive state, then we can control the incidence of the cancer. So the 4 level of care, because now I am again going to cover a little bit administrative part. So at what level we have to discuss, like at community level, at primary care level, at district hospital, at secondary care level, and central and referral center level. So at community level, what we can do? Like we have to make them aware, yes, cancer cervix type of entities exist and it's a public health problem. And we are having various methodology. So we can give vaccine, we can screen, so we can decrease. So community awareness, education, counseling is very important. Okay, and what we should do at primary care level, secondary care level, and tertiary care level, that we'll see. So in community, health workers may be involved in raising awareness about cervical cancer in the community, that I told you, because once they know that the disease exists, then they will do something. Motivating and assisting these women to use services like HPV vaccine services and screening services, and following up those who have received a positive screening test, that I will talk a little bit later on, and those who have been treated at higher level of care when they return home. What the primary care providers do, they can promote services and conduct screening, follow-up and counseling, and can refer their patients to higher level facilities as necessary, including provision of clear information about what to expect at those facilities. And what we do, district level center, they perform a range of diagnostic and treatment services and refer patients to both higher and lower level of care. As outlined above, these providers may also be charged with program consideration. A tertiary care provider manage patients with invasive and advanced cancer and refer them back to lower, that is primary and secondary level of care when appropriate. So again, I am coming to this graph. We already discussed that HPV infection is high after sexual activity and up to the age of 25. So on this, there are primary prevention. In primary prevention, our focus is between girls of 9 to 14 years, and we can vaccinate them. And not only we can vaccinate them, we have to do counseling, because tobacco chewing is also risk factor for cancer cervix. So we should give health information and warning about tobacco use, sexuality education tailored to age and culture, condom promotion, like basically early sexual activity is one of the risk factors for cancer cervix. So what counseling we can do? They should delay sexual debut. They should avoid multiple sex partner. And while they should use condom. Okay. And male circumcision is also one of the protective factor against cancer cervix. Now, what is secondary prevention? Secondary prevention, I already discussed earlier. In secondary prevention, we try to diagnose disease in the early stage. So in secondary prevention, that starts with 30 to 45 years. Here, we do screening. Okay, so screening with a high performance test equivalent to or better than HPV test. This topic is very well covered by previous speaker. I am not going in detail. And not only screening, this is screening followed by immediate treatment or as quickly, as early as possible. I cannot see this. And in tertiary prevention, when we diagnose the disease, now patient is having cancer. It may be early stage, it may be late stage cancer. So we have to treat, like if it is early stage, we have to do surgery. If it is a late stage cancer, then we have to give treatment by radiotherapy, chemotherapy, and palliative care. So like when these are cancer survivor patients, when there is a complication, then we can alleviate their anxiety, psychological support, and pain. That is important thing as a palliative care. Now, what happens? Next. Yeah, so a little bit I will cover this cancer. So this vaccine is a primary prevention, and we are having, because already the previous speaker told this cancer cervix is caused by HPV, and we are having 100 types of HPV, but only 14 or 15 types of HPV causes cancer cervix. And out of this 14 and 15, that 16 and 18 variety causes more than 70% of the cancer. And in India, this 16 and 18 is responsible for 80% of the cancer. So this Cervarix vaccine initially covered the two viruses, that is 16 and 18. And here are 3 doses were there, 0, 1, and 6 months. Okay. Then another Gardasil is there. Gardasil covers the 6, 11, 16, and 18 HPV virus. What is the plus point? These 6 and 11 are responsible for genital warts. So it will not only protect you against cancer cervix, but also warts also. One more thing I would like to highlight, this HPV cancer also causes anal cancer, vaginal cancer, vulval cancer, in boys, penile cancer, and oropharyngeal cancer. So if a girl or a boy receive these vaccines, so they are protected against this 6 type of cancer and warts also. And now we are having Gardasil, that is a nanovalent. So it will cover 9 types of vaccine, this 9 types of HPV: 6, 11, 16, 18, 31, 33, 45, 52, and 58. Okay. And schedule is again 0 to 6. Now, regarding the Cervavac, this is the Indian made. I can proudly say this is the Indian made. Serum Institute of India has manufactured this vaccine in collaboration with the DBT, and it is going like phase 3 and 4 trial. And hopefully, we'll get this vaccine in our national immunization schedule, because these vaccines are costly, and this is one of the drawback that we cannot cover our population. So once we'll get clearance by 4-phase trial, and with the support of Indian government, maybe this will be included in the this national immunization schedule. So again, Cervavac we can give 0 to 6 months. So these are 4 types of vaccine. Okay, in USA, they are preferring nowadays Gardasil 9 because it covers the 9 HPV. But in India, we are having quadrivalent. So again, but 16, 18 causes 80% of this cancer cervix. And there are cross reactivity also. So there may be a little bit cross protection against 31, 33, 45, 52, and 58. So now, what is the dose schedule? What is the dose schedule? Vaccine is available as a 0.5 ml dose, and we can give intramuscularly in the deltoid region. Now, optimal dose, what is ideal? So when a girl receives 2 doses when she is less than 14 years, so between 9 to 4 years, she should receive 2 doses. So 6 months apart, because it's suppose I am taking example of Gardasil. Gardasil ka dose is 0, 2, and 6. So if she is receiving this vaccine before 15 years of age, so she can only receive 2 doses, that is 0 and 6. And if girl is more than 15 years, then she should receive 3 doses, that is 0, 2, and 6. Okay. If it is Cervarix, then 1 month. But okay, I am talking about Gardasil, so 0, 2, 6. And our Indian made is also Cervavac 0, 2, and 6. And 3 doses for older women till 45 years. So ideally, this vaccine should be received before initiation of sexual activity. But even a patient is sexually active, a woman, girl, then she should receive this. Because suppose after sexual initiation of the sexual activity, she is infected with 16 and she is receiving this vaccine Gardasil. So she is still protected against 18. So older women can also take this vaccine, and they should take like 3 doses. Now WHO is also recommending reduced doses because these vaccines as of now costly. Okay, and most of the cancer cases are in the developing country. That's why now WHO and SAGE is recommending that, okay, 1 or 2 doses for 9 to 14 years, 1 or 2 doses for 15 to 20 years, 2 doses for 21 years and above. But you can see this is the level 2 recommendation. What is ideal? That is level 1 recommendation, that we should take less than 15 years 2 doses, more than 15 years 3 doses. Okay, and one alternative single dose schedule can be used for girls and boys at 9 to 20 years. For boys, yes, boys can be vaccinated because I told you these causes penile cancer also and warts also. Warts can be there in the boys. So boys can be vaccinated from 9 to 26 years. So again, 9 to 14 years, 2 doses, 0 and 6 months, and 15 to 26 years, 0 to 6 months. This is a level 2 recommendation. Okay. Now, because I thought now I should tell about this vaccine in detail. So I took some points like regarding safety. Till now, 9 to 10 crores girls received this vaccine, and these vaccines are very safe. Okay. So no issue regarding safety. Side effects, just like any other injection, a girl can have a little bit pain or swelling at the side of vaccine. Contraindications, there is no contraindications of the vaccine, except if girl or woman is allergic to any like constituent in the vaccine. How long protection lasts? So this protection up to 10 years, so already studied, because this vaccine started in 2006. So now we are having up to 23. So up to 10 years, yes, protection is there, and still studies are going on. In older women, I already told you, older women also can receive this injection if that woman is affordable. Okay, but we have to tell them sexually active woman or sexually active girl also can receive this vaccine, because I told you, suppose she is infected with 18, but still she is protected against, because we are having in monovalent other vaccines also. It's 16, 18, 31, 33, 45, 58. So she will be protected against other HPV viruses. Okay. So yes, pregnancy we can take, or no pregnancy, it is not recommended. But second thing, suppose inadvertently a patient received this vaccine, so there is no indication of abortion, she can continue the pregnancy. Okay, but she should avoid in pregnancy. And lactation, yeah, it is very safe. She can take during lactation. In boys, I already discussed you, the Cervavac vaccine, our vaccine, and Gardasil Nano, that both are licensed for use in boys. But the thing is, our main focus is cancer cervix. So if resources are limited, we always recommend that girls should receive first. Will it affect sexual behavior? Some say, okay, once a girl will receive, then she will be like very casual about sexual relationship. It doesn't, it is not like that. We have to do counseling. And will it affect fertility? No, it is not going to affect fertility. So these vaccines are very safe. And I urge you all, because in spite of telling many people, the first thing is, yeah, cost effectiveness is there, but yeah, awareness is also not there. Some type of fear is also there. So I'm telling, if you can afford, please advise your girls, your sisters, okay, and your other relatives, because so many, most of the audience are paramedical and I think so medical staff. So please do counseling. And if you can afford, please receive. Even if you are more than 26 years of age, you can receive too. All the nurses I'm urging, or the doctors I'm urging. Okay. So what is it? Because I have to cover little bit administrative part also. So what is the strategic action to achieve 90% of the coverage? Because what is our goal? 90, 70 and 90. So I'm talking about 90% coverage of HPV vaccination. So we already saw success of polio vaccine in our country. And in polio vaccine, you have to maintain the cold chain. And we already did this thing. This vaccine also, we have to keep it 2 to 8 degrees centigrade. So yes, political, but in HPV vaccines, vaccination success is, there is a political will. So yes, we need political will to cover this, afford this availability of this vaccine. So secure sufficient and affordable HPV vaccine. Yes, that is the political will is there, should be there. Increase the quality and coverage of vaccination by involving efficient and sustainable multi-sectoral delivery platform like schools. We can go to school, we can keep, we can do counseling, and we can cover. So school immunization program and innovative community-based approaches to reach vulnerable population. What is the vulnerable population? That is the adolescent girls who are not in school. Improved nationwide evidence-based communication and social mobilization. I told you, people are not aware about this vaccine. Even the person, they are affordable, they don't know. So we have to make them aware. So counseling is very important. Education is very important. Evidence-based communication and social mobilization efforts, which will require an understanding of social, cultural, societal, and other barriers that may affect the acceptance and uptake of the vaccine. Okay, just like they may think, parents may think it will increase the sexual, abnormal sexual behavior, not abnormal, irresponsible sexual behavior. So it is not like that. We have to counsel them. National guidelines, policies, and strategies to improve the efficiency of vaccine delivery. I told you, and we already showed during our Pulse Polio program, because in this vaccine also we have to maintain the cold chain. Should be updated as new evidence and innovations become available. In addition to HPV vaccination, a comprehensive prevention strategy must include. I told you, not only we have to vaccinate, we have to do counseling regarding sexual behavior, that they should delay sexual debut, age delay, Decreasing the number of sexual partners, they should use condom, and male circumcision can be advised. So along with vaccination, we have to do counseling regarding these factors also. Now, secondary prevention. Secondary prevention is the screening. So my previous speaker already covered, but again, let me little bit explain. So screening, this is the secondary level prevention in which we are trying to diagnose the pre-invasive things. So check the available resources. She already told that which HPV and pap smear and one more thing, VIA. So we, according to our resources, we have to use logistics available, finances hai ki nahi. For cervical cancer screening, it should be acceptable, affordable, and sustainable. Okay, we started HPV testing, and after 2 months we have to stop because funds is not there. So it should be acceptable by the people, it should be affordable, and it should be sustainable. That is most important. So in good resource setting, yeah, primary HPV DNA testing every 5 years, and age group is 30 to 65 years. Now, why for they took 30 years for HPV? When we go to this chart, this you just see. So here, if we before 30 years already HPV infection incidence is very high. So if you do screening with HPV before 30 years, so we'll get the HPV positive. That's why HPV testing should be advised after 30 years. Yeah, pap smear we can start at the age of 25 years. So she already covered. Okay, then acceptable cytology every 3 years from 25. You just cytology from 25 we can start, but HPV DNA we have to start 30 years because already patients, women and girls are already infected with HPV DNA in early age. Okay, and VIA every 5 to 5 years. She already discussed what is VIA. I am not going to tell. In low resource setting, she already told you HPV test wherever available. Otherwise, VIA visual inspection with acetic acid every 3 to 5 years of age, and age is 35 to 60 years. Okay. Now screening techniques, she already told pap smear, HPV test, and VIA and Willy. I'm not going in detail. Then she already told when we should start. So 25 years in good resource setting, universal recommendation, 30 years, level 1 evidence. When to stop, 65 years, she already told. But provided, it's not like that one woman, she did testing at 30 years. And after that, 65 years, and she stopped. No, provided she should be regular in her previous screening. Because if she is doing pap smear every 3 years, so in last 10 years, 3 pap smear tests should be negative. If she is doing HPV DNA we do every 5 years. So her last 2 pap smear HPV DNA tests should be negative. And the most recent test should have been performed within 5 years. Okay, test interval already discussed. Screening with hysterectomy with removal of the cervix. Suppose hysterectomy done for fibroid, then no need for screening. But screening hysterectomy done for CIN3, again, then she has to do follow-up. Because this invasive, pre-invasive disease, these are the multifocal lesion. Means not only cervix is involved, there may be in via vagina may be problem, vulva problem is there. Okay, so it may be spread. So if CIN2, indication of hysterectomy, CIN2 or more than this, then she has to do follow-up with the pap smear from the vulva. That is important. And in immunocompromised woman, we have to screen early, that the 25 years, and we have to screen very frequently. What happens, like HIV patients, their longevity is increasing nowadays because they are on ART. But what happens, because of their HIV status, they are getting more incidence of this cancer cervix. So basically, in these patients, HIV infected patient, we have to do a little bit, frequency will be more. Now, primary screening. Okay, one question was asked with my previous speaker. If HPV, suppose one pap smear test is positive, then what to do? So basically, screen, there are 2 approaches are there. One approach is screen and treat. Other approach is screen, diagnose, and treat. So screen and treat, suppose a patient is a primary healthcare center, she went there. And there is a VIA positive is there, white lesion is there, just she showed you, white lesion is there. And we are making diagnosis, yes, it is a dysplasia, that's a pre-invasive lesion. So there only we can treat, we can, one ablation, either we can ablation means we destroyed that lesion, or we can excise. So ablation can be done by thermoregulation or by cryo, and excision by leak. So 2 approaches there, screen and treat. So in rural area, when people are coming from far area, so pap smear will take 7 days, 4 days, 5 days. HPV DNA testing will take again 1 week. So we will lose the patient. So their compliance will not be there. So in such cases, we should screen and treat. Okay. If we are negative, again, she can come after 3 years. If it is positive and lesion is suitable for ablation, we can do cryo. If lesion is not suitable excision, then we can excise. I'm not going in detail, but yeah, we will not leave the patient because we are screening positive. It's not like that. It is unethical to leave the patient. And why we are doing screening? We are doing screening to diagnose the disease in the early stage. Okay. So it's not like that after screening, she has to come. No, we have to take treatment. She has to take treatment. Otherwise, we have to. So this is these things what we will do if screen test is positive. Second method, this method is in the good resource setting. So suppose her HPV DNA or pap smear is, in her pap smear, LSL is there, low grade squamous intraepithelial neoplasia. Then next is colposcopy. We should do colposcopy. And in colposcopy guided biopsy, we should do. Ideally, colposcopic guided biopsy, we should do if pap smear test is abnormal. So I'm not going in this detail, but yeah, definitely one message I want to give you. If screen in positive, we cannot leave that patient. We have to follow up. If you are, in such cases, suppose a primary health center, if screen is positive and their facility is not there. That's why I showed you my second or third slide. Community level, what we have to do, primary health center, what we have to do, secondary health and tertiary care. So support PSC pe VI is positive and they are not having facility, then they should refer the patient to district hospital. Their cryo is there, or there is a facility for pap smear. So pap smear is positive, or they can do colposcopy. Okay, suppose in colposcopy guided cancer has come, then the tertiary care level center, they will refer the patient to tertiary level center, because cancer patient should be operated by oncosurgeon, either gynae oncosurgeon or oncosurgeons. Unfortunately, in India, general surgeons and gynecologists are doing the things. So basically, ideally, they should be trained for gynae oncosurgery, and these cases should be done. Cancer cases should be done by gynae oncosurgeon. So that's why it is very important. Referral center, and once they operate the patient or after giving chemotherapy, radiotherapy, they can again send the patient to the district level for follow-up, because patient is far and she cannot come again and again. Okay, so strategic action to achieve 70% coverage of screening. So we already covered the 90% HPV vaccination. Now focus is 70% coverage of screening. Now screening, I showed you in that chart that between 30 to 45 years of age, there are highest incidence of pre-invasive lesion. So we have to focus those age. So that's why our target is all women up at the age of 35 years, they should screen for in 70% of the cases. And again, at the age of 45, again, 75% coverage is there. So again, what we have to do, these are the administrative things, understand barriers to access services and create an enabling environment. Again, we have to mobilize community. We have to educate them, integrate screening and treatment. That is very important. If we screen, okay, test, we took sample and then send the patient, and we are not giving treatment, then there is no sense of screen the patient. That's why integrate screening and treatment services into the primary care package. Promote a screening treat approach that I already explained. Countries will need to expand the number of facilities where a single visit screen and treat approach could be implemented. Ensure an affordable supply of quality assured high performance screening test and treatment devices. Strengthen laboratory capacity and quality assurance program. I can understand that every primary health care center, we cannot have laboratory services, but at least district level center, secondary level center, we should have laboratory capacity, so we can take pap smear. If we are taking biopsy, so pathologist should be there to diagnose the things. Okay. Now, strategic action to achieve 90% treatment and care for cervical cancer. Our third target was 90% treatment. So to whom? 90% treatment means pre-invasive lesion also we should treat, and 90% cancer patients also get treatment. So what we should do, administrative things, implement cervical cancer management guidelines. Every country, WHO gave the guidelines, and every country should make and then follow. Establish referral pathway, very important. If screening positive at primary, they can refer to secondary level. If some in biopsy positive cancer is there, then they can refer to secondary, tertiary center level. So people centered linkage. Strengthen pathology services, understood, is clear. Expand surgical capacity. I told you, The gynecologists should not operate. They should take training in cancer surgery, and oncologists should treat this patient. Improve access to radiotherapy and chemotherapy. Unfortunately, this radiotherapy and chemotherapy is not available in all the government setup. So yeah, government should make it available. Strengthen and integrate palliative care services. I told you, advanced cases when treatment is not possible, at least we should give symptomatic relief. Optimize health workforce competence throughout the continuum of care, understood. Reduce cancer stigmatization by patient awareness. One thing I want to make it clear, it's not a sexually transmitted disease. Okay, don't think it's a sexual. If woman is sexually active, almost all the women can get this HPV infection in their lifetime. Even they are having single partner. So don't think, okay, this risk factor is not there. I am not having multiple sexual partners, so I cannot have cancer cervix. Don't think like that. You can get HPV infection, and that persistence of HPV infection lead to pre-invasive lesion. So now we are having two things. We should be vaccinated. And second thing, after vaccination, screening should continue. It's not like that I took vaccination, so there is no need of screening. Why? Because there are 14 or 15 types of HPV viruses, but quadrivalent vaccine is covering only 2, 16 and 19, and nanovalent is covering 7 types. 2 are for 6 and 11, there are for Watts. Okay, so don't think this is message. Even if you are vaccinated, your screening should continue. Provide comprehensive support designed to enhance the quality of life and address physical, psychological, social, and spiritual challenges faced by survivor. So tertiary prevention, that I told you, they should receive treatment advance. If early case is there, we can give treatment in the form of surgery, because in early cancer cervix, surgery is the treatment and it is curative. And if it is advanced cancer, yes, chemotherapy and radiotherapy can be given. And cancer survivor patients, palliative care to relieve pain and suffering. So again, a referral mechanism for primary care provided to facilitate that cancer offer and treatment. Accurate and timely cancer diagnosis by exploring the extent of invasion. And depends on the staging, we have to treat the patient. Early cases, surgery, advanced cases, chemoradiation. Now, what are the key points? Development of any national cervical cancer prevention and control program should be done in accordance with the WHO framework of the 6 building blocks to strengthen the overall health system. I will tell what are those 6 building blocks. Cervical cancer prevention and control programs are developed and designed to decrease cervical cancer incidence, morbidity, and mortality. There are large inequities in access to effective cervical cancer screening, like these cancers are common in rural area. The patients are not educated and they cannot access. And those women who can access, those are not having those risk factors. So this inequality is there. Okay. So there are large inequities in access to effective cervical cancer screening and treatment. Invasive cervical cancer predominantly affects women who lack access to these services. A comprehensive program should include primary, secondary, and tertiary prevention activities, including treatment and access to palliative care. Screening services must be linked to treatment, that I am highlighting again and again. And post-treatment follow-up is very important. Monitoring. Now we are providing these services. So we have to monitor and evaluate these services, where we are going wrong, why we are not, we are achieving our targets or not. So monitoring and evaluation are essential components of the cervical care prevention and control program. So these are the 6 building that I told you, system building blocks. There should be leadership and governance. So political will is there. Financing should be there. Then medical products, vaccines, and technology should be make it available. Information to the people. We should have health workforce, and with that we deliver the services. It will lead to improved health, responsiveness, social and financial risk protection, and improved efficiency. Now, the development and implementation of the National Cervical Cancer Prevention and Control Program include the following phases. First is national policy development and establishment of a program management structure. Second is program planning and preparation, program implementation, program monitoring and evaluation, and supervising and training. Just like anything we are doing, we have to do monitoring. Otherwise, how will know? It should be sustainable. That is very important. So again, think repetition. At primary level, we can do VIA. If VIA is positive, we can send the patient to secondary level, maybe district hospital. Okay, for pap smear or colposcopy or treatment, that is cryotherapy, if they diagnose there, then we can send to referral tertiary level for cancer treatment. Then again, after treatment, they can go to for follow-up, because this cancer patient, they have to come for follow-up every 6 months and 1 year. And lifelong follow-up is there. So that follow-up they can do at secondary level or the primary level. And along with the training, monitoring, and evaluation should continue. So this is the same administrative thing. I don't know how much I should cover, but yeah, at national coordinator at the Ministry of Health, and one national coordinator there, we should have multidisciplinary management team, stakeholder advisory group, then working group who provide service delivery, human resource development, one working group for community education and mobilization, working group for needs assessment and monitoring and evaluation, and guideline development. So 5 key message about the screening and treatment. Cervical cancer is a disease that can be prevented by very effective HPV vaccination. There are tests to detect early changes in the cervix known as pre-cancer or pre-invasive that may lead to cancer if not treated. But what is the plus point? There are safe and effective treatment for these early changes, and all women aged 30 to 49 years should be screened for cervical cancer at least once, and that age is 45. No one need to die from cervical cancer. So this is the chart for surveillance and monitoring. Suppose we are providing HPV vaccine, then we should see the vaccine coverage, and we have to maintain vaccine monitoring system, immunization register. And for screening, how much screening coverage is there? We have to maintain screen registry. So this is for surveillance and monitoring of the provided by the WHO. So these are my references. If you want to read more, you can go through this comprehensive cervical cancer control, WHO 2014. Thank you so much. Wait, because I got my one question. Yes, Sina.
Okay.
You meanwhile, I'll come within 5 minutes. Because one patient was sick.
Ma'am. Okay, thank you so much, ma'am. I think there is some important work for ma'am, so ma'am will be joining here. Thank you so much for participating from. Yes, if anyone wants to ask any queries, please write down in the chat box. We will take up your questions from here, and I have seen few questions in YouTube also, ma'am. There are few questions, like some of them they have asked, like at what age we can start vaccinations?
I told you 9 to 14 years. After 9 years, you can start.
Okay. And
if you'll give before 15 years, because this vaccine cost, I think, so 3,000 something. So if you start before 15 years, like at the age of 10 and after 6 months, so you have to give only 2 doses. That is plus point if you start early.
Yes, and even they are saying like once they will get the first doses, what should be the time interval between the 2 doses?
Yeah, actually, second dose should be after 6 months. But like there is a range. Some relaxation is there. So 5 to 12 months. Like first dose you feel you are taking today, so you can take 5 months or 6, 7 months, preferably 6 months. But 6, 7, 8, 9 up to 12 months. Second dose you can take.
I think, I hope you got the answers. A few of the people, they have asked in YouTube also. Yeah. Like they are even asking whether the vaccine is free or...
No. This vaccine till now it is not available in our national immunization schedule. But yeah, we are hoping, because we already made our vaccine. We are expert making vaccine after COVID pandemic. So we are having Cervarec, that vaccine, but it is undergoing trials. As of now, it is not freely available. We have to purchase. But yeah, you can go and talk to your gynecologist, and definitely you should receive, and you should advise to your daughters, sisters, other female relatives.
Yes. So I hope you got the answer.
One question I can see, can vaccination affect the libido of a person? No, vaccination is not going to affect the libido. I told there is no effect on fertility also. That already covered in my topic. Yeah, libido, no effect on libido.
Okay. One more questions they have asked, like after delivery, when they can start their vaccinations?
Yeah, immediately after. If you are in the hospital, you can take at that time also, because it will be easy to get the injection. In lactation, you can receive, no issue. Immediately after delivery also you can receive, no issue.
I think you got the answer. Anyone wants to share any experience with this, with the use of vaccinations, or anything you have which you wanted other people also to know? Please feel free to share. share your experience. And if you want to ask any questions, you can raise your hand. Ridisa, you want to ask some queries, you have raised your hand. Toda, also you have raised your hand. If you want to ask queries, either you can write down in the chat box or we will give access. So one question is asked by Sweetie, what are the signs of cervical cancer?
Yeah. So basically, that is the drawback that cancer cervix in early stage doesn't cause any sign, any symptoms. Okay. So that's why when patient have signs or symptoms, it means it's already late. So in advanced stage, she will have like dirty discharge or postcoital bleeding, means after sex they have bleeding or dirty discharge there. Or suppose it spread surrounding area, then she may have backache. Okay, sometime dribbling of urine, but that is in advanced cases. Early stage patient usually doesn't have this symptoms. That's why we have to screen. Okay, but yeah, that patient may complain postcoital bleeding, means after having sex she will have bleeding, or spotting off and on. Yeah, means it is she is having regular menses during her periods, like regular, and in between intermenstrual bleeding she can have. Okay, spotting off and on.
Okay, I think you got the answer, Sweetie. I think I'm not able to see any more queries in the chat box, either in the YouTube also and here in Zoom as well. So if anyone want to share any experience, anything, please feel free to do that. Otherwise, we will move to our last sessions. I think Sir has already joined. Dr. Raj sirs, are you there? You are able to hear us?
Can I take leave?
Hello, Dr. Raj, you are here? Okay, sir. I think my slide is visible. So, Jyoti ji, hello. Can you hear us?
Yes.
Okay, I think sir is already there.
Sir is sharing the screen, I think.
Okay, sir is here. Okay, so
You are
I
sharing or
hope,
sir
sir,
sharing?
sir, you are able to hear us. Hello, Raj sir. Sir, can you hear us? Hello. Jyoti ji, can you call him? I think sir is either. Sir, mic is unmute. Can you hear me? No, sir, we are not able to hear you.
Sir, we cannot hear you, sir. Could you please check the mic?
Hello, sir. Yes, sir. You can reconnect with the audio, sir.
Okay, so as well, basically you can transfer the patient here and you keep me informed. Okay.
And I hope those who are joining from the YouTube also, please be in the sessions. After the sessions, I will share post test in that chat box only, as well as I'll share the feedback link also.
Again, she's having hypertension.
Sir, now can you hear us?
It was second time for hypertension. Yeah.
Ma'am, sir is joining back, ma'am.
Okay. Hello, did sir has joined back?
No,
Hello?
Raj sir has not joined, madam. He will
Okay,
join
sir
right now.
is.
He's
Oh,
joining.
wait.
Hmm.
Sorry, we will have a last session, so please bear with us. Sir is joining back. So if anyone wants to share any experience, anything, please feel free to either write down in the chat box or you can unmute yourself and you can share, okay? Sir will be joining back soon. Then we will start our last sessions.
No, Sir has joined. Sir has joined and I've made him co-host.
Okay. Sir has joined back. Hello, sir. Can you hear us? Lafina, I'll give you the feedback link as well as post test, okay?
There's something wrong in this mic, maybe. Sir is not able to speak.
Okay. Okay, coming. We are really sorry because of this technical glitches. We are facing a lot of problem today.
Look, actually, I have to go. I am seeing OPT. Today is my OPT day, na?
Okay.
Sir, we can't able to hear you, sir.
On
Sir is again muted by host. Sir has written in the chat box. Can you please try him to again unmute? Sir, you are unmuted. Can you hear us, sir?
Sir is already on mute.
Again, sir, we are not able to hear you. I think sir will be trying to join back again. If anyone wants to ask any queries, you can ask. Certificate I'll give you in your respective mail. After some time, I'll message you in the WhatsApp group. Those who are in a WhatsApp group, okay, I'll message you once it is done. Jyotiji sir is able to join now.
Sir is trying to join again.
Okay. Actually, sir was traveling, so that's why he couldn't able to join before. So please bear with us. Yes, whatever email ID you have given in the link while doing registrations, you will get in that same link, okay? And I think many of your friends are in the WhatsApp group, which I have created long back. You can ask a link and you can join directly, or you can message me, okay? After some time, I'll give you my number. You can message me directly also. I will add you in the group. So in future also, whatever webinar or any training will be conducting, then I'll inform you in that same group.
Sir already joined कर लिया नानुका मैम.
Hello, sir. Can you hear us now?
अच्छा, gents, can you talk to sir?
Sir is unmuted, but again, we are not able to hear from sir.
Can you hear me now?
Yes, sir. Yes, sir. We can hear you now.
Yes, sir,
Can
we
you
can
hear me
hear you,
now?
sir. Thank you
Yes,
so
sir.
much.
Yes,
Yes, sir,
sir.
we can hear you, sir.
We can hear you, sir. So, thank you so much for joining with us, sir. So, today we are having now, this is the last session. So, before going into the main topic, I just wanted to introduce our third presenter. So, sir is Dr. Raj Sankar Ghosh. Sir is working as a technical advisor for immunizations, One Health, climate change, and disease surveillance. Sir has worked as a physician with 3 decades of experience in policy, planning, and delivering of
Can
public health
you
programs.
hear me now?
Yes, sir, we
No.
can hear you. Yes, sir.
Sir, we
Yes,
can
Can
hear
you
you,
hear
sir.
me now?
yes, sir.
Yes, sir, we can
Yes,
hear
sir.
you.
I can't hear them.
Yes, sir, we can hear you.
Hello?
Yes, sir.
Good. But I can't hear you now.
Okay, sir. Sir, I'm just,
Okay.
okay, sir. So sir has worked in
So
a
I'm
West
assuming
Bank.
that you can hear me now.
Yes.
Yes, sir. Yes, sir. Yes, sir.
Yes, sir. I'm just introducing. So sir has worked in a
Wonderful.
West Bengal health.
So it is a one-way traffic that I understand. That I can hear you, but you cannot hear me, or
Yeah. I think then.
yes, now I can hear you. Can you hear me now?
Yes, sir. Yes, sir. I can hear you. You can hear me.
Wonderful. Yes,
Okay.
now I can hear everyone. Wonderful.
Sir, I'm just introducing you for to the participants, sir. I'll just finish within a minute, then I'll hand over to you, sir.
Wonderful.
So, sir has worked in a West Bengal State Health Services as a medical officer in a primary health center, and also work as a regional coordinator in the National Polio Surveillance Project of WHO, and as a director of immunizations for South Asian region at Path India office. Our most recent assignment was a senior advisor immunization at the India office of Bill and Melinda Gates Foundations. Currently, sir is providing technical advices to the national as well as the international organizations on One Health, climate health, disease surveillance, and immunizations. So, sir is also a recipient of honorary fellowship from Indian Public Health Association for his contributions to public health in South Asia region. So we are very much honored to have you, sir, with us. So I wanted to hand over the platform to you, sir. Over to you, sir.
Thank you. Absolutely my pleasure, my honor to be with all of you today. So will you be sharing the presentation, or should I?
Sir, it's up to you. You want me to share?
You can
So I
share the
can.
presentation. You can share the presentation.
Okay, sir. Okay,
Yeah.
sir. I'll do that. Just a minute, sir. I'll just share.
Okay. Let me see if I can share the screen, then I will try to do. Actually, I can do it. I can do it. So I have done it from my end. Thank you
Okay.
so much.
Okay, sir.
Okay. Thank you.
Over to you, sir.
Okay. 1 second. Let me do a few things and then.
Sir, from here?
Yes. Can you hear? Okay. 1 second. Just. Can you see the screen?
Yes, sir. Sir, can you do in a slide, sir?
Yes, I
More,
will
sir.
do that. Yes. Okay. So all of you can see me and hear me now. Thank you
Yes.
so much. And my sincere apologies for this technical error. It's a real pleasure and honor to be with all of you. Thank you so much for inviting me. My conversation today is going to be around the vaccination program, HPV vaccines or cervical cancer vaccines. And we will look at cervical cancer vaccine in the light of cervical cancer elimination in India. So there are 2 caveats that I want to put before we start the conversation. One caveat is that you all know that India has not yet launched the cervical cancer or HPV vaccine in its universal immunization program. So therefore, the conversation that we will have is still the policy making process that has happened in India on cervical cancer vaccines. And we will hear a little bit about how new vaccines are introduced in India. The second caveat that I have is that cervical cancer vaccine is a very powerful tool, but there are other components of cervical cancer elimination that we will briefly touch upon, because alone vaccines will not be able to eliminate. We will need all the different elements that need to work together to eliminate cervical cancer from India and from the world. So we all know that there is a cervical cancer elimination global initiative. The global strategy is to eliminate cervical cancer as a vision of a world where cervical cancer is eliminated as a public health problem. That means that a threshold of 4 per 100,000 women years for elimination as a public health problem needs to be achieved. The 90, 70, 90 targets that must be met by 2030 for countries to be on the path towards cervical cancer elimination. Most of the countries, including India, have committed to the 90, 70, 90 target by 2030. The 90, 70, 90 target means that 90% of the girls will be fully vaccinated with HPV vaccine by age of 15 years. 70% of women are screened with a high performance test by 35 years of age and again by 45 years of age. And 90% of women identified with cervical cancer disease receive treatment. That is, 90% of women with pre-cancer are treated and 90% of women with invasive cancer are managed by the health system of the country. This is the 90, 70, 90 target, strategy target that World Health Organization has coined, and many countries across the world have signed to this pledge, including India. Second. So as I was saying that, cervical cancer vaccination is a very important tool, but it has to be kind of managed with the other strategies that are there for saving lives from cervical cancer. The Saving Lives is an acronym that we have coined. S stands for screening for precancerous cervical lesions. A stands for access to services, both the diagnostics and the vaccines, treatment and palliative care, vaccination with safe and affordable and effective vaccines, and E stands for education for action to address misinformation and disinformation on cervical cancer. So all of these different elements around screening, around access to services, around vaccination, and around education of the common people and of the healthcare providers is an important pillar based on which cervical cancer elimination will happen. Now let us come to cervical cancer vaccination. As we discuss about cervical cancer vaccination, first thing that we will look at is around the different kinds of processes and pillars on which a new vaccine is introduced. Because now we will be considering the Indian chapter of how a cervical cancer vaccine needs to be introduced. Now, there is a process that we call, which is called the P process for introduction of any new vaccine. It starts with that there is a public health problem which a vaccine can address, which means a cervical cancer is a disease, a public health problem that can be addressed by vaccines. Now, once we have identified that it is a problem, all of you know that a problem never comes alone. There are multiple problems that come together. So there is a cervical cancer problem, there is a pneumonia problem, there is a problem of rotavirus diseases, there is a problem of typhoid, and then there are many other public health problems. So therefore, with limited resources that the public system has, we will have to prioritize the problem based on the data that is available. And we will talk about how the prioritization is done a little later. The third thing is that when a prioritization is done, then a policy is made about how the vaccine needs to be introduced into the program. The next part is once the policy has been taken, the government and the immunization divisions, they look at what are the different kinds of products, which means vaccines are available for introduction in the program. And there are lots of factors based on which the product is selected. One of the important factors is the price of the vaccine, because the vaccine must be affordable for introduction into the National Universal Immunization Program. Once the price is understood, that this is the price, then the funding source has to be identified. Where does the funding come from? Is it given by the government? Does it come from an external source like Gavi? Or is it kind of taken care by some international donors like the World Health Organization, UNICEF, the Bill and Melinda Gates Foundation? And then, based on that, once this price and the funding source is identified, then procurement happens. To give you an example of the funding, for example, when Rota vaccine was first introduced in India, a very small amount of support had come from Gavi. And Gavi had initiated the introduction of Rota vaccine in India. And then the government of India took it over and funded the entire program. Similar in case of the pneumococcal vaccine, some of the initial vaccination program was supported by Gavi. And this is not only true for India, but this is true for all middle and low income countries across the world, where Gavi supports the initial introduction of the vaccine and then the government takes it up. Once the source of funding is identified, then the procurement process happens. And once the procurement is done, then there is the planning for how the vaccine will be introduced, where it will be introduced, when will it be introduced, how will it be introduced. And then the program happens. The program is rolled out. Once the program is rolled out, we understand the new problems that come up in terms of the quality and the coverage. And then again, the whole process is repeated in terms of how the program should be scaled up within the country. Now, in introducing any new vaccine, and say, for example, the cervical cancer vaccine, when it will be introduced, there are 4 I pillars on which a vaccination program, particularly a new vaccination program, rests. The first I is integration. How does the vaccine integrate into the universal immunization program? In terms of scheduling, in terms of the delivery, in terms of whether it needs to be run in a campaign mode or it needs to be run through static booths, fixed sites. The second thing that we look at is around the impact of the vaccination program. Therefore, there are various monitoring and evaluation tools that are put in place in order to understand how the vaccine is impacting on the health of the children and the adolescent and the adults for whom the vaccine is meant for. The third is that in the program, various kinds of innovations are brought. These are both technological innovations and community-based program innovations. For example, when COVID vaccine was introduced, it is a new vaccine. It was introduced into the country. One of the innovations that was done was COVID. And similarly, when hepatitis B vaccine was introduced in 2006, the auto-disable syringes were introduced. And the last thing, which is very, very important, is that the program needs to be institutionalized within the system, within the health system. Therefore, the states and the national program, they institutionalize the program so that there is uninterrupted funding for the program in moving forward. Now we will come to the first P, which is the public health burden of cervical cancer, which is the problem. You have been hearing, I believe, throughout the day about cervical cancer as a public health problem. So I'll be very, very brief in this. The first thing that you know about cervical cancer disease burden in India, and this is what is reported, that there are more than 500 million women aged 15 years or more in India. These women are at risk of developing cervical cancer at some point of their lifetime. It is estimated that every year, There are around 124,000 women who are diagnosed with cervical cancer, and of these, around 77,348 women die from the disease. Again, this is what is reported. A large number of cases go unreported, both in terms of the disease and the deaths. And the third thing that is important to know is that in India, almost 80% of cervical cancer and 63% of the high-grade cervical lesions that happen are associated with type 16 and type 18 of the human papillomavirus. Cervical cancer is the second most frequent cancer in Indian women in the high-risk age group of 15 to 44 years. It is estimated that close to 5% of women in India are infected with HPV 16 or 18 at any given time of their age. It is also worthy to note that more than 80% of invasive cervical cancer is attributed to HPVs 16 and 18. This is the WHO India report in 2021 on cervical cancer. We know that the crude cervical cancer incidence per 100,000 women in 2020 was around 18.7. The eighth standardized cervical cancer incidence per 100,000 women is 18. The cumulative risk of cervical cancer aged 0 to 74 years is 2%. Cervical cancer deaths in 2019 were 45,300 that were reported. And the cervical cancer mortality to incidence ratio is 0.62. And the population-based cancers registry exists in India, and therefore it is reported. However, as we said, there is a lot of underreporting that has been found in various surveys conducted in India. The next important thing as a evidence for policy making and prioritization, which we discussed earlier, is the economic burden of cervical cancer. There are various studies that have been conducted. One of the studies shows that there is a very high out-of-pocket expenditure for cervical cancer in the community. For example, for a cervical cancer treatment, which includes all the different types of therapies and surgery, it ranges from around 20,000 to 41,000 rupees. Furthermore, it is understood that patients spend around 4,000 to 23,453 rupees. And there was a 30% reported distress financing because of cervical cancer. And one of the evidences that is very, very clear is that cervical cancer has a huge out-of-pocket expenses for the community. When they happen, the poor become poorer, and there are still the level of maturity of services provided for cervical cancer is still not very mature. So therefore, in very remote areas and in the vulnerable population, the economic burden of cervical cancer is much higher than what happens in the privileged population. One of the things that is also looked at is what is the economic benefit of cervical cancer vaccination in India. There is a very nice paper that you all can look at. The link is all here. It's by Dr. Tiago M. de Carvalho and her team. Under the base case scenario of lifelong protection of a single dose vaccination in 10-year-old girls with 90% coverage, which is the target, the discounted incremental cost-effective ratio of nationwide vaccination relative to no vaccination was around 30,000 per DALY, which is the disability adjusted life years averted. So this clearly provides a very high evidence for prioritizing and introducing the HPV vaccine within our universal immunization program. This also shows that a 2-dose vaccination versus no vaccination, the economic benefit of that was around 1,04,000 rupees. And the ISR for 2-dose vaccination versus single-dose vaccination is around 169,000, 1,69,000 per Delhi averted, is the evidence that we have from this paper. Now we come to the next P, which is the prioritization. In case of prioritization, there are various examples that are there. For example, there is a good example from the state of Sikkim about how they prioritized. The state political leaders, they prioritized HPV vaccine introduction. They allocated state government budget to procure the vaccine from the manufacturer directly. The government of Sikkim identified financial resources for procurement and completed desired approval processes. The vaccine procurement was done both for the doses and for the provision to sustain the program in the long term. So therefore, they clearly looked at the data, they looked at the evidence and took an evidence-based decision for recommending HPV vaccine in the state. There are some critical factors that countries have taken into consideration for prioritizing HPV vaccine. These are 4 of the most important factors that they have considered. One is that they have looked at the locally driven processes that are adapted for introduction of the vaccine. The health systems vary from country to country, from state to state. Therefore, states must look at their own health systems in order to make their decision for HPV vaccine introduction. The resource allocation is a very important factor that the states must look at for prioritization of HPV vaccine. They must look at availability of local data and the infrastructure, particularly the supply chain for the delivery of the vaccine. And lastly, they must identify partners from across various stakeholders, from the doctor community, from the general community, from various faith-based healers, from various kinds of different sources that are there in order to ensure that there is a robust program for the HPV vaccination. Now we come to the policy. There's a very clear policy from WHO. That WHO position paper states that the priority purpose of HPV vaccination, which accounts for 82% of all HPV-related cancers, the 2020 WHO Global Strategy to accelerate the elimination of cervical cancer says that it must be included in all national immunization programs and should reach 90% of all girls by age 15 by 2030 across the world. In case of the NTAGI recommendation, which is the National Technical Advisory Group on Immunization in India, they have taken a stand on this. They have recommended the introduction of HPV vaccine in the universal immunization program with a one-time catch-up for 9 to 14 years old adolescent girls, followed with routine introduction at 9 years. The vaccination would be provided primarily through schools in order to reach those girls who are unable to attend school on the campaign day. The vaccination would be provided at a health facility, while for out-of-school girls, the campaigns would be conducted through community outreach and mobile teams. In case of the SAGE, which is the WHO Technical Advisory Group for making recommendations on vaccines, they have recommended that over the past many years, there is emerging evidence that a single dose schedule provides comparable efficacy to 2 or 3 dose regimens. So SAGE's review concluded that a single dose of HPV vaccine, which are pre-qualified by WHO, provides adequate protection against HPV compared to 2 dose schedules. The NTAGI recommendation, based on it, the state level recommendation at Sikkim has been that the vaccine will be introduced in the state to 9 to 13-year-old girls based on WHO recommendations. Now we come to the various types of vaccines that are available in the market in terms of globally. And these are vaccines which have been also approved by the local, the Drug Controller General of India within the country. And there are 6 HPV vaccines which are globally available. Out of those, 4 have been approved by the Drug Controller General of India: Cervarix, Gardasil, Gardasil 9, and Cervavac. And these are the various kinds of, 6 vaccines which are available. And the variant of the human papilloma virus that is within these vaccines. And there are various manufacturers. In India, we have the quadrivalent Cervavac vaccine, which is manufactured by Serum Institute of India. And in the private sector, there are various vaccines which are used, including the Gardasil 9, and the Cervarix. Now, when we look at the HPV vaccination strategy in India, when the discussion was going on about how the vaccine needs to be introduced based on the NTAGI recommendation, there are a few things that were looked at. One was that the vaccine must be compatible with the delivery infrastructure and the cold chain capacity, which is the health systems strengthening initiative that the government of India takes. It must be affordable and sustainable within India's universal immunization program. And the third is a very important aspect of ensuring that we have a very high coverage with HPV vaccine in India, because without a high coverage, we will not be able to achieve the impact that we discussed earlier. There are 2 ways of introducing it. One is the 2-dose schedule, and one is the single, and the other is the single-dose schedule. In 2-dose schedule, it is used in the primary target age group of 9 years of age, and for all older age groups for which HPV vaccine is licensed. There is a minimum interval of between first and second dose of 6 months. A 12-month schedule results in higher the kind of GMTs, which is the amount of immunogenicity that we have within the body, and is suggested for program and efficiency reasons. There is no maximum recommended interval between doses, and longer interval up to 3 to 5 years can be considered if useful from a programmatic perspective. But these are all WHO guidelines. India will make its own guideline. In terms of single dose, as an off-label option, a single dose schedule can be used in girls and boys aged 9 to 20 years. There is a current evidence, as I discussed by SAGE, that the vaccine can be used as a single dose, and it has a comparable efficacy with the 2-dose variant that is given in the various immunization programs. For immunocompromised patients, regardless of age or antiviral therapy or status, they should receive at least 2 HPV vaccine doses with a 6-month interval minimum, and wherever possible, a 3rd dose should be given to them. HPV vaccines can be co-administered with other non-live and live vaccines using separate syringes and different injection sites. And the vaccine have different, though HPV vaccines have different characteristics, components, and indications, in settings where several vaccines are in use, there is an effort made now to administer the same vaccine for all doses when using a multi-dose schedule. However, if the vaccine used for the prior dose is unknown or unavailable, in that case, HPV vaccine can be administered to complete the recommended schedule. The vaccine is highly efficacious in both the HPV 16 and HPV 18 variant particularly, and almost it is 88% with a 95% confidence interval between a confidence interval. The vaccine safety is very high. Since licensure in 2006, over 500 million doses of HPV vaccine have been distributed globally, and the Global Advisory Committee for Vaccine Safety have clearly stated that the vaccine is very safe whenever used. We do not have any adverse event reporting which is uncommon or unexpected in the program, and therefore across all the globe, newer countries are now adopting HPV vaccines for their programs. However, this is also a very important reminder for us to say that India's And any country which introduces a new vaccine like HPV vaccine, the pharmacovigilance system must be strong enough in order to capture any kind of events that happen which can be alerted and considered as adverse events following immunization. So therefore, we must have a strong pharmacovigilance system in order to introduce any new vaccine in the program. These are the countries which have introduced as of December 2022 across the globe. These are the countries which have introduced HPV vaccine. India is yet to introduce. Very recently, Bangladesh also introduced the vaccine. HPV vaccine introduction in India, the policy is very, very clear. We have a very strong recommendation now from the National Technical Advisory Group on Immunization, and therefore, the government of India is now contemplating the introduction of HPV vaccine in its universal immunization program. 2 states, Sikkim and a part of Punjab, some few districts of Punjab, they have already introduced the vaccine. For example, in case of Punjab, Bathinda and Mansa district have introduced the program, whereas the whole state of Sikkim has introduced the program. And there are wonderful documents which are available to show the impact of HPV vaccine in these states. The delivery strategy that has been planned is that a multi-age cohort campaign for a 9 to 14 years can be considered for routine immunization. When India introduces, they will take their call, but this is something that is seen globally as has been impactful. There is a class or grade-based approach for vaccination. All girls enrolled in class 9 to class 10. Age-based approach, all girls aged 9 to 14 years. Any eligible girl in a school not studying in these classes can be line listed for vaccination. Bangladesh is following the same model for their programs. The schools are a very good platform where the vaccine can be delivered, outreach sessions, health facilities, and mobile teams going around to vaccinate girls are all of the different delivery platforms that are used. And ideal, there is an organization called Jivika Healthcare, which has conducted a few HPV vaccination programs in urban areas of Delhi, Maharashtra, Karnataka, and they have set up some models which are good to look at. For example, how the camp is set up, how the counseling is done, the waiting process, the vital checkups before the vaccination program, the registration, and these days there is digital registration, therefore it becomes much more smoother. The vaccine administration, the card distribution, and now with digital, we have a much simpler way of card distribution and the post-vaccination observation of the girls after they have received the vaccine. So this is all that I had to tell you today. India, when it introduces the program, will make its own plans and program guidelines, and the policy has been taken. There is supply of vaccine, so we will all wait as to when India takes the call for introduction of HPV vaccine in its program. Thank you.
Thank you so much, sir. Thank you. So anyone wants to ask any queries here, you can write down in the chat box or you can raise your hand so that we can unmute you. Thank you so much, sir, once again for the wonderful presentations. So
Thank
here
you.
I have seen one questions in the, sir, actually from the YouTube also people were joining. So there are approx 550 participants are there in the YouTube. So some of them, they have asked questions like why it is a high risk in the rural areas compared to urban places, sir. So one of the questions has been asked by one of our participants.
Right. So it is not about that we have found a very high risk of difference between urban and rural area, because when the program is launched, it is launched both in the urban and the rural area. One of the things that happens is that the education plays a very important role. Education about cervical cancer. The second is access to health services. So often in the urban area, there are private care providers and all of them who provide a service in terms of the early diagnosis and all of that. But the government of India has now taken up cervical cancer diagnostic and screening very seriously. So we should be able to ensure that at the sub-center level, at the primary healthcare level, we will have these screening methods available, and there the rural population can benefit a lot. Thank you.
Thank you so much. I hope you got the answers. So, sir, one more question was asked by Ribahun, like, can a woman of any age get vaccinated? And for how many doses they should get if they want to get vaccination? I think yes, sir.
We made that in the presentation about the age group that they need to get vaccinated, 9 to 15 years of age. The important thing that one needs to understand that the protection needs to happen early. There are two things that are being considered. One is a 2-dose vaccine and one is a single-dose vaccine. There is very strong evidence now from WHO, SAGE, looking at the efficacy of a single-dose vaccine. And so therefore, if the single-dose vaccine happens, then the compliance will be high. But as of now in India, there is no policy taken around the single-dose vaccine. Therefore, a 2-dose vaccine, as is being given in the private sector and in the states like Sikkim, is available. When the government of India takes a call on this, based on the recommendation of the experts at the NTAGI, then we can definitely say about how many doses. As of now, I will say 2 doses of vaccines need to be taken, because that is what the government of India's current policy is.
Thank you, sir. I think I'm not seeing any more questions out here. If anyone wants to share any experience, if you have already taken the vaccines or after vaccinations or anything, if you want to share and you want to let other people know, so please write down in the chat box, or you can raise your hand. I've seen a 2 hand raised, like Toda and Rinki. So if you want to ask, you can write down in the chat box or you can unmute yourself. So, sir, one more question is asked, like, whether HPV vaccines is only for, wait, sir.
Girls.
Yes.
Okay. So HPV vaccine is primarily for girls because of the, prioritization. Public health is all about prioritization. If we vaccinate all the girls, then the boys are also protected. But vaccination can also be given to the boys. But because there is not availability of uninterrupted resources, and also there is not uninterrupted availability of vaccines, therefore currently the policy is to vaccinate girls. When there is enough vaccines, when the price of the vaccine is much lower, then the boys will be considered. At risk are the girls. If we are able to vaccinate more than 90% of the girls, the boys will be protected accordingly.
Thank you so much. I think I'm not seeing any more questions in the chat box, even in the YouTube also. So,
thank you.
Thank you so much, sir. And I think here, approx 1,000 participants here through Zoom and then YouTube. I hope you got knowledge from this webinar, and we hope even if 10 people also got vaccinated with the HPV, then we will feel blessed that at least this webinar had some value on it. So, sir, I think one more question is they asked by Sunita, like 30+ women can take 2 doses of vaccine anytime they can take, sir?
They can take vaccine. They should consult their gynecologist, obstetrician about their need of the vaccine. The general program will cover between 9 to 14 years of age, based on the profile of the person, based on their current age group. They should consult beyond 15 years of age, beyond 18 years of age. They should consult their local gynecologist and obstetrician and take a call on at what age they need to get the vaccine.
Okay, thank you, sir. So I think in YouTube also they are saying whether vaccine is free or not. That one we have already discussed.
Absolutely. When the vaccine will be available in the universal immunization program, which it is not now, it is free. In Sikkim and in the districts of Punjab where they are available free of cost at the vaccination centers, at the government vaccination centers.
I think, but in other state, those who are joining from other state, I think it's
So
not
it is not
free.
available free of cost because it is not in the routine immunization program of India. It is only available in the private market. And that is why the government of India is trying to introduce it so that the benefit can reach out to more people. It is not available free of cost outside of Sikkim and Punjab.
Thank
There
you.
are certain NGOs who give the vaccine. Therefore, those they will be providing free of cost.
Okay, I think I think one question is asked by Sangma, like how many doses of HPV vaccine will be administered the girl age group? I think that things we have already discussed. And
Yes, 2 doses or 1 dose based on the data that is available. That's a call that the government of India will take.
okay, thank you. So I think I will share the most of you are already in the WhatsApp group. So I will share all the PPT today itself so that at least you will go and, share, use as a reference for future webinar or anything if you want to host also. So I think we came to the end of the session today. So
Thank you.
first of all, I just wanted to say extremely sorry for so many
No,
technical glitches that happened today.
no, not at all. Thank you so much, everyone. Have a wonderful day.
Thank
I
you,
will
sir.
take leave then. Thank you.
Thank
Thank you
you.
so much, sir.
Thank you so much. So on behalf of Jupaiko and Nigrims, I would extend my gratitude and thank you to all the participants and to all our presenters who have given lots of insight in this topic. Thank you so much, sir. Thank you. And those who have not received, having problem with the post test and feedback, I'll share in WhatsApp group as well. Thank you, everyone. Thank you. I think, James, you can end the session.
Shall we close the session?
Yes, we can close the session.
By 1 second.
James, you can close the session now.
By let it run for some time. I've stopped the recording. Let anyone that wants to attempt post test and everyone that wants to give feedback will be able to give it now.
Yes, at least we can do that one. Those who have not received the post test and feedback, they can do now. And those who have already completed, you can leave. Sorry, and thank you so much.
James, we can collect the
James, you can stop the live YouTube streaming.
Yes, ma'am.
Anji. And I think we can end now. I have submitted in the WhatsApp group also pretest, post-test and feedback link also. I hope everybody has done. So see you next time. And I think you can end.
Yeah, we can end it. James bhai, we are ending it right now. हाँ, लाइव स्क्रीन सबसे पहले बंद कर देता हूँ। कर दिया। एंड